Hello everyone, myself Usman Ali from DVM 9th semester, Group C2, UAS Lahore. The topic of our discussion today will be infertility in a mare with a chronic uterine tear, diagnosis and successful standing hand-assisted laparoscopic repair. The topic will cover the diagnostic approach and then the treatment and then post-operative care. First of all, going towards the introduction, uterine rupture is the potentially fatal peripartum complication in the mare. As you know, uterus is a delicate structure, so any trauma or any injury can lead to laceration. The reasons include dystrochia, uterine torsion, hydroamnios trauma, or any manual contraction during falling. Case background is that we had a patient 8-year-old 550 kg thoroughbred mare. The history included 16-month infertility following two falling seasons. The previous falling were in 2006 and 2007, with the fall with uterine hematoma in the first, and the second falling resulted in a stillbirth due to premature placental separation and hemorrhages. The other reproductive findings included that the estrous cycle was normal, and once there was also an early embryonic loss on the day 19th post breeding in the third cycle. First of all, and the endometrial cultures were negative for the infection, so any physical trauma or physical injury was expected. So, because the mare was in good health upon admission for the diagnosis, the hematology and biochemistry was normal. Upon transrectal palpation, the corpus luteum was observed on the ovary, the cervix was closed, and there was no uterine fluid. Upon ultrasound, there was also no abnormality found initially. Diagnostic approach. Then we approach for laparoscopic examination. What we did for this, that uterus was infused with 3 liter of 0.9% normal saline and examined via video endoscopy. There was small hole observed in the uterine horn connecting to the abdominal cavity. Fluid noted between uterus and bladder confirmed the communication. You can see here in the picture as well. The diagnosis, it was confirmed that full thickness uterine tear in the right uterine horn. Then we approached for the treatment. Then standing exploratory laparoscopy was used for the diagnostic approach. Diagnosis was confirmed by the visualization of peritoneum through uterine defect. Then we have to go for pre-operative management. We know, any surgery can't be performed with the gut fill. So feed was withheld for 24 hours before surgery. Broad spectrum antibiotics was used like gentamicin, ampicillin, luxenmeglumine. Sedation was used using dopamidine and butorphanol. Then we approached towards the surgery. The surgical technique including standing hand-assisted laparoscopic approach via right palumbar fossa. Laparoscope inserted through guarded trocar technique, and the tear was visualized in the right uterine horn. It was 2 centimeter in diameter and 15 centimeter from the tip. The surgical technique used. The uterine horn was exteriorized. First of all, the bulged endometrium was debrided. Then two-layer technique was used to suture. The inner layer was sutured with simple continuous suture. The outer layer was sutured using Lambert pattern, and surgical site was then lavaged and abdomen was closed. In this way, the uterine tear was reduced, and the post-operative care included administration of the antibiotics, procaine, penicillin, gentamicin, and for pain relief, flunixin meglumine was used. Uterine manipulation was done per rectum every 2 days for 2 weeks. Outcome was very favorable. The mare was bred successfully 8 months post surgery and it delivered a healthy foal. No postoperative complications such as wound adhesions or dehiscence was observed. Chronic uterine tear presented as infertility rather than illness. It was a unique case because there was full thickness there without signs of any peritonitis, likely due to immune control and anatomical contraction limiting bacterial spread. High value of laparoscopic was used for diagnostic purposes. Uterine tear may go undetected post-parturition. Routine transsexual ultrasonography may miss localized tears. Combination of hysteroscopy, ultrasonography, and laparoscopy ensures accurate diagnosis. Standing surgery avoids anesthesia risk. Following the conclusion, full thickness uterine tear can manifest as infertility. Standing hand assisted laparoscopy is safe, minimal invasive, and surely effective. Comprehensive postpartum reproductive examination is essential. Key lesson is that combine multiple diagnostic techniques for reproductive disorders. Thank you very much for your listening. If you have any question, let me know in the comment section. I will surely answer that.